Welcome to Bullet Point Nursing. My name is Dr. Goldstein, and in this lecture, we're going to go through mental health or psychiatric pharmacology. We split this into two videos. This first one is going to be depression and anxiety, and we're going to do a second separate video on bipolar, ADHD, insomnia, and schizophrenia. Let's go ahead and start with some basic pharmacology principles in terms of dealing with mental health medications. So first of all, for testing purposes, dysphoria is the medical term for depression. So you might see a test question that asks you about a patient experienced increased dysphoria, and that means the same thing as increased depression. All mental health medications should always be tapered down. Patients should never suddenly stop taking their antidepressant, their antipsychotic, etc. Patients should be educated that they need to understand and be realistic about what this medication is going to do. A patient should never think, I'm going to go to the doctor, they're going to give me some Prozac, I'm going to take it today, and tomorrow life is going to be sunshine and rainbows. It's going to be so amazing, the best it's ever been. That's not realistic. We have to make sure patients understand. It takes 2 to 4, sometimes even up to 6 weeks for patients to get the full effects of a medication. What I like to tell patients in my clinic is that if, let's say, they're starting on a new medication like sertraline or Zoloft, medications we're going to learn about today, I'm hoping that when I see them again in 30 days, they're going to tell me, things are a little bit better. I don't feel down as much, or I don't feel stressed out as much. They should notice some gradual improvements, but it takes time for that, and they need to understand that. Generally, when we're giving a patient medication for mental health, we're always also educating them on getting psychotherapy, on getting counseling or exercise or yoga, meditation, some of the other non-pharmacological interventions for depression or anxiety or whatever they have. However, generally, the most recommended is going to be therapy. Next, every single patient who's being treated for mental health, especially if they're on medication, even if they're perfectly stable and they've been on this medication for 10 years, they still always need to be asked about risk of suicide on testing. That's going to be a really big one that we're going to ask about. There is a complementary and alternative medication. It's St. John's wort that patients take for depression. Keep in mind, this CAM, I'm not recommending it or not recommending it, but it does work very similar to our medications. And that's important for you to know, because if a patient is taking this CAM, plus they're taking our medication, the two can interact with each other and cause the patient to overdose, which, as we're going to learn about today, in this specific case, results in serotonin syndrome. Next, let's talk a little bit about serotonin syndrome before we get to the drugs that can cause it. This is where a patient's serotonin level gets too high. We're going to learn in just a minute that a lot of the medications we're going to work with today for depression and anxiety increase a patient's serotonin levels. And if the levels get too high, they can end up in serotonin syndrome. There's no specific way to treat it. We treat this by managing the patient's symptoms. The symptoms include things like tremors, fever, altered mental status. There's a whole long list. I didn't pick these 3 out for any particular reason, but there is a really long list in your textbook about the symptoms of serotonin syndrome. What causes serotonin syndrome? The 2 most common issues. One is a patient's put on too high of a dose, especially if they're put on too high of a dose too quickly. And the second issue is if a patient's taking multiple serotonin medications. Finally, I don't know how much this will be on a pharm test, but I do think that this is fair game for your pharm test. You do need to understand the assessment tools that we use for a patient that has depression or anxiety. And that would be, for depression, the most common is the PHQ-9. For depression, that would be the GAD-7. Now let's start to talk about the actual medications. Now, again, this lecture is depression and anxiety medications. And for the most part, these are going to be the exact same medications. Depression and anxiety have a lot of overlapping symptoms. However, the easy part in the fact that there is an easy part in the fact that we don't need to distinguish between whether a patient's having depression or anxiety for the purposes of medication, because they're treated the same pharmacologically. So the first line universal treatment for anyone who comes in with depression or anxiety, and it's to the point that we want to put them on medication, are going to be the SSRIs. The SSRIs include some of the most common medications that we use. In fact, this drug class is certainly in the top 10 of all prescriptions given in the United States. The drug class include the brand names that you're probably familiar with: Zoloft, Lexapro, Prozac, Celexa, and on the generic names, which is what we're going to start to use, sertraline, fluoxetine, escitalopram, citalopram, and paroxetine. How do these medications work? They work exactly like the name of the drug class says. They block the reuptake of serotonin. So what does that mean? Serotonin is something that the body constantly produces and the body constantly gets rid of, just like everything else. And we've seen this a bunch of times if you watched other lectures. We do this often in pharmacology. We use this concept that the body is constantly producing a chemical or substance and the body's constantly getting rid of it. If I want to increase the level of that substance, in this case serotonin, I block the body from getting rid of it. but the body's still producing it. So now it's producing it without getting rid of it. The levels go up and up. So that's how this medication works. It blocks the body from getting rid of serotonin. Increased serotonin increases a patient's mental health. It reduces their depression, reduces anxiety. It does have an off-label use for premature ejaculation. In that case, it's going to be specifically paroxetine, even though all of these can have that side effect. So let's talk about it. The most common side effect with these medications would be insomnia, which is why we tell patients to take it in the morning. And as long as they take it in the morning, it's pretty rare to have that issue. The second side effect that we test on and that we teach is that it can cause sexual dysfunction. In women, that means that it makes it longer or impossible for them to achieve an orgasm, which is a negative effect. However, in men, it makes it longer for them to treat an orgasm, which makes them last longer, which is what premature ejaculation is treated with. When patients have premature ejaculation, they come to an orgasm too quickly. And in this case, the medication helps them last longer. This medication does have a black box warning that has a risk for suicide. You can see that with pretty much every single drug we're going to talk about today. My 2 cents is that probably just a lot of these patients that are taking these medications also happen to have that risk for suicide. I don't know how much the medication actually causes a risk for suicide. I would assume that's pretty small, because otherwise we wouldn't be giving these to our patients. However, it is a black box warning, so we're going to follow that. These medications are the first line drugs, as I told you, and they are considered safe in pregnancy. Again, I put relatively safe because at the end of the day, we don't want patients taking medication in general in pregnancy. However, if a patient needs this on any level in order to function better, have a better quality of life, keep things together, especially during pregnancy, 100% they should be taking this, no question about it. Next, we have SNRI, serotonin norepinephrine reuptake inhibitors. This does the same thing. It blocks the body from getting rid of serotonin, but it also blocks the body from getting rid of norepinephrine. So it does a lot of the same thing. And again, it will increase your serotonin level plus your norepinephrine level. What do we use these for? We use it for the same thing, depression, anxiety, but these are not a first-line drug. The rest of the drugs we're going to talk about, I don't say second or third or fourth line. In NP school or MD school we do, but right now we're just going to say it's other than first line, because exactly where to go next, whether you go to this or the next drug class or one of the other ones, is way beyond what we're going to get into an RN level. An RN level, we want to know what the first line is, and then we want to know what is other than first line. And in case I haven't mentioned this or you haven't seen this in other videos, it's important to know what's other than first line, because in most cases that means, or pretty much in all cases, that means the patient's already been on the first line drug and it didn't work for one reason or another. It could have been as simple as they were allergic to it, or it could have been that it wasn't enough to help their case, which could be a hint to you that maybe it's a touch more complex than, I don't want to say run-of-the-mill depression, but a mild depression. So the drugs we're talking about here is duloxetine and venlafaxine. The brand names there are Cymbalta and Effexor. We've already talked about the mechanism of action. These are used for anxiety and depression. These are also used on label for migraine prevention and fibromyalgia, which is neuropathic pain. Now, these medications have the same side effect of sexual dysfunction and insomnia, but they have additional ones. They can cause hypertension. They can cause orthostatic hypotension. They can cause hepatotoxicity and anorexia. Some people do lose weight on these. Not that that's a good thing in some cases. In some cases it is. But in patients that have depression and they're already not eating, this will be a pretty bad choice, because this really takes away your appetite and can cause anorexia. And finally, it has the same black box warning of that risk for suicide. Next, we have our tricyclic antidepressants. The drugs over here are going to be amitriptyline, nortriptyline, doxepine, imipramine. Some of these drugs have been around a really long time. And in fact, when we go back to the history of mental health pharmacology, these are the drugs that were at one point the first line drugs. However, they have definitely fallen out of favor because of the SSRIs, which are so much safer. How do they work? They do the exact same thing as what we just said. They increase the level of serotonin and norepinephrine by blocking the body from getting rid of it. However, it works on a chemistry level a little different than the SNRIs, which is why it's in its own drug class. But at the end of the day, it has the exact same net effect. What do we use this for? These are used for depression, and then it has off-label uses such as anxiety, fibromyalgia, and a few other things. Now, when we're given these medications have an anticholinergic side effect. So hopefully you've heard me say this a bunch across all our videos, but anticholinergic side effects means the patient's going to have dry mouth, dry eyes, urinary retention, constipation, etc. And for all drugs that can cause anticholinergic, remember, for test purposes, be ready for some questions like who would be appropriate to recommend, fiber fluids, things like that, or cough drop or eye drop. It would be anyone that's taking anticholinergic drug, because that would be non-pharm relief of those conditions. These drugs also can cause ECG changes. In fact, if patients overdose on these drugs, we can definitely get to some ECG changes that could become life-threatening and can even be fatal, which is, again, a big reason why this is not a first-line drug like it used to be a few decades ago. This medication also causes CNS depression, orthostatic hypotension, sedation, and weight gain. Again, side effects is a big part of what we test on with TCA, so I would definitely know those. Black box warning is the same as all of them. And again, this is not first line. Moving on, we have the MAOIs. This is our last resort medication in almost all cases for the treatment of depression or anxiety. These medications have a bunch of issues with them. They block monoamine oxidase. Monoamine oxidase is responsible for getting rid of norepinephrine, dopamine, epinephrine, and serotonin. But all of these medication, all of these chemicals in our body will go up, and that does treat depression. It has the same black box warning as we talked about. MAOIs very famously interact with a ton of medications. In fact, if you're going through all of pharmacology, I'm pretty sure warfarin and this one, phenelzine, probably have more interactions than pretty much anything else. So because of that, if a patient's put on this, you have to go through their med list and see what else they're on and make sure there's no interactions with it. And if a patient is on this and gets put on a new medication, you need to go back and see that this new medication doesn't interact with their MAOI. There are a bunch of contraindications. I didn't list them all here. Some of the major side or adverse effects are orthostatic hypotension. However, they can develop hypertension if they take tyramine. I'm going to talk about that in just a second because that's a really common test question. In fact, and when you look at all the pharmacology test question banks, if you get to a question about MAOI, this is by far the most popular, is its interaction with tyramine. So let's jump to that real quick. If a patient is taking MAOI, they need to stay away from tyramine. Tyramine is an ingredient in tons of foods. It's in cheeses, salami, bananas, beer, wine, and it's a really long list of about 25 different major food groups that have tyramine. The patient must avoid all of these. If they take them, they can end up extremely hypertensive and end up in the hospital or worse. Other side and adverse effects are insomnia and anticholinergic effects. When a patient is coming off of an MAOI, they need to stop this for 14 days and then start a new medication if it's a medication that interacts with this. Not just, okay, your next medication interacts with this, we need to stop the MAOI and put you on something else. We need to stop the MAOI, wait 14 days, and then put you on the next medication. Next, we have bupropion, which is commonly known as Wellbutrin. We don't know exactly the mechanism of action, but we do know it blocks the uptake of norepinephrine and dopamine like we keep talking about. However, this medication is becoming, and again, this is not a first-line drug. It's a other than first-line drug, but this is becoming very popular as our go-to second-line agent. What do we use this for? We use it for depression. Also, the same ingredient is in the medication Zyban, and in that case, it's used for smoking cessation. This can be used off-label for ADHD and bipolar. I can tell you it's not that common. However, it is common for primary care providers. If they want to dabble in trying to treat ADHD, sometimes they'll put a patient on Wellbutrin and see if that helps. Obviously, generally, ADHD is not treated in primary care. It's treated by the specialist, the psych mental health NP, or an actual psychiatrist. This medication has a risk for seizures and insomnia and the same black box warning. Next, we have trazodone. Trazodone is a very interesting drug for one simple reason. It's officially a drug for depression. However, we don't use it a lot for depression. Let's talk about it. The mechanism of action is it blocks the reuptake of serotonin, increasing the serotonin effect, plus it blocks histamine. It blocks histamine. Blocking histamine is something like an antihistamine, such as Benadryl, that knocks you out, puts you to sleep. This drug puts you to sleep. And trazodone is used more as an insomnia drug than an antidepressant, which is what makes it interesting because it's officially only an antidepressant, yet the vast majority of all prescriptions for trazodone in the United States are not to treat depression. Again, it is one of those other than first-line drugs, but actually the most of the time we use this is for insomnia. I've been to some hospitals that actually this is their standard go-to insomnia medication for patients, let's say in the ICU, that are having some trouble sleeping. Side and adverse effects, dizziness, drowsiness, dry mouth, ECG changes, and orthostatic hypotension. That one's pretty common with most of the antidepressants, the orthostatic hypotension, other than with SSRIs. That one is, there's a reason it's the first-line drug. And again, we have the same black box warning, risk for suicide. Next, we have buspirone. We don't use this a ton of it. This is just for anxiety. This isn't used a lot for depression, but it can be. It does have an off-label use for depression. It does have the same previously mentioned side effect of the sexual dysfunction. Plus, this has a risk of developing EPS, which we talk much more about in the next mental health video where we talk about schizophrenia. But that's one downside to it. but in general, this isn't that commonly used, but it is certainly out there. So I did put it on here, and it is fair game for your test. Finally, for anxiety, because let's talk about acute anxiety. For acute anxiety, our go-to drug class are the benzodiazepines. The benzodiazepines is a huge drug class. There's a ton to learn about it. We talk about it in multiple of the pharmacology lectures because it's used for so many different things. I'm not going to get too detailed into it here, but it is a anti-anxiety medication. It's what we use for panic attacks or acute anxiety, as they're officially called. The mechanism of action is that it's a GABA agonist. GABA is the brakes of the brain. It's an inhibitory neurotransmitter. And the more we activate GABA, the more we get CNS depression. It slows down and starts to turn off the brain, which is why we get that sedation. That's why we can use it for insomnia. That's why you can calm a person down when they're having acute anxiety. The side effects, muscle weakness, because this is also a muscle relaxant. It does have a side effect of hypotension, that it will drop the blood pressure. So make sure you're assessing that. It can cause sedation. And sometimes we use it specifically to cause sedation. And it can cause respiratory depression. Respiratory depression and hypotension would be the two biggest, most important, highest priority, hint for your test of what a nurse would monitor for in a patient receiving a benzodiazepine. Patient education is the same as the black box warning. Do not mix this with other CNS depressants such as alcohol. And just like every controlled substance, which this is, it can cause addiction and dependency. This is of the safest or least addictive of the controlled substances. That's why it's down at a Schedule 4, as opposed to like our opioids, things like that are up at a Schedule 1 and 2. This is the first line drug for an acute seizure, which is nothing about what we're talking about today. And again, this is going to be not for chronic anxiety, which is most of what we talked about, the SSRIs and that. This would be for acute anxiety. One last note, and then we're done with this lecture, is that there's a drug called propranolol, which is 100% fair game for your test. That's a beta blocker drug that we also discuss in a ton of different lectures. But propranolol specifically is a beta blocker that we use for situational anxiety. Why? Because in some patients that have anxiety, their anxiety is attributed to the fact that they feel their heart racing and their blood pressure pumping and their heart's just pounding out of their chest. They get a lot of those cardiovascular symptoms with their anxiety, and that sort of pushes their anxiety even further. A beta blocker stops that. A beta blocker blocks beta, which means it blocks the ramping up effects of the heart, so the heart rate stays low, the blood pressure stays calm, and the patient doesn't get that heart beating out of their chest that pushes them even further. So for those patients, it's a really good drug. It's not at the top of our list by any means for anxiety, but it is a acceptable drug, especially when someone has something like test anxiety, if any of you have that. Especially when someone has test anxiety, they can't afford to be on other acute medications like a Xanax, because that's going to knock them out for their test. This doesn't knock you out one bit. All it does is keep your heart rate from getting too high, your blood pressure from getting too high, from getting your body all worked up, which makes your anxiety worse. If you have any questions, please reach out. Please subscribe and like our video. Here's the references for you to look this stuff up, and have a great day.